started. Hello, everyone. Good afternoon, and thank you for attending the ACCP IMTR PRN New Practitioners Council webinar, The Role of a Transplant Pharmacist. My name is Stephanie Asechko, and I'm a solid organ transplant pharmacy clinical specialist at Cincinnati Children's Hospital Medical Center, where I practice primarily in both inpatient and outpatient pediatric lung transplantation. Today, I am here with my co-moderator, Brittany Nguyen, who is a solid organ transplant pharmacy clinical specialist at Mayo Clinic Hospital in Phoenix, Arizona, where she practices in adult abdominal, kidney, liver, and pancreas transplantation. It is our pleasure today to moderate the webinar, which is geared towards students and residents to gain a better understanding of the various roles of a transplant pharmacist. And we have an incredible lineup of speakers for today's webinar. To start, we have Dr. Zena Wong from New York Presbyterian and Columbia University, and then Dr. April Padabam from Nebraska Medicine, followed by Dr. Abby Lino representing Cincinnati Children's Hospital Medical Center. And finally, to wrap up, we have Dr. Jennifer Gray from CareDx. In a moment, I will turn it over to Dr. Wong to begin her presentation, but first, here are a few quick notes. If you are calling in today, please ensure that your phone is on mute. If at any point during the presentation you have a question for the speaker, please submit that question directly to me via the chat functionality. We will take questions for all speakers, as Brittany mentioned, at the completion of the presentation and facilitate discussion thereafter. And then if you have any technical difficulties with this, please just submit your question or comment through the chat functionality to everyone directly. All right, now, so without further ado, I will turn it over to Dr. Wong to begin her presentation today.
Okay, everyone. Before I pass it on to Dr. Wong, I just want to make sure everyone can see my slides or her slides. There you go. Okay. All right. Passing it over to Dr. Wong.
All right. Thank you both. Good afternoon, everyone. My name is Sina Huang. I'm an assistant professor at Long Island University, and I practice as a heart transplant clinical pharmacist. So I have to name my presentation title as Heart Work in Action, but I will be talking about inpatient transplant pharmacist live. Next slide, please. We'll be talking about the essential breadth of transplant pharmacist activity across the patient care spectrum, and some core responsibilities, and essentially how I sort of get to where I am today. Next slide, please. So I do understand that we do not teach a lot of transplant in pharmacist school, and I will be the first one presenting. So I just wanted to sort of lay the groundwork a little bit before I dive into what I do. So transplant as a pharmacy specialty, we do have a very clear guidance document on the ASHD that highlights essentially what we do. But to break down sort of what we do in terms of scope of practice. So you will see a lot of transplant pharmacists, they do have board certification to signal that they're at clinical expertise. So we'll see the credential BCTSB after their names. We do have a very broad patient care activity or responsibility, and we do emphasize a lot that we practice as a multidisciplinary team member, and we do get involved a lot in quality improvement projects or research, and we participate a lot in transplant center protocol development. And lastly, we do a lot of research naturally as a growing field, and also as a result of our quality improvement involvement. And you will see why we are so involved in so many different aspects. I'd say largely we are granted a lot of legislative positions that you probably will not see me mention in other pharmacy specialty areas. So just a little bit background, we do have a transplant specific law back in the 1980s, essentially to mandate the safety, scientific background, efficacy of transplant, and also the organ allocation. And under the law, essentially umbrellaed under the law, they do require pharmacology expertise in it. And pharmacists naturally serve as the role of the pharmacological expert. And also for CMS, like Medicare, Medicaid programs, they do mandate transplant pharmacists or pharmacists have transplant background training to be participating as the team member. So just some plug for career security and career path right there. Next slide, please. And for the purpose of today, I'll be focusing on my patient care responsibility, especially as the inpatient pharmacist. And just to give, I guess, some vision of where we see the patient. So essentially, when we were talking about transplant, right, the patient needs to be evaluated for a transplant, get the actual transplant, and then have the post-transplant care. Brittany, if you can just click through a couple, yep. Thank you. So essentially, when the patient gets evaluated, they may be seen in the clinic setting where if they're more stable, or in the inpatient setting. That's probably more case for me. My patients, probably 70% of them are like ECMO or get hooked up through some sort of mechanical circulatory devices. And for the actual transplant, it will be happening in the inpatient realm. And if they have post-transplant complications, they may be readmitted. So as you can see, I'll be seeing the patient throughout their transplant journey for those specific time points when I'm practicing as an inpatient pharmacist. Next slide, please. So we've been talking about multidisciplinary team a lot, but I just sort of want to show you how transplant pharmacists sort of fit into the team. It takes a village, really, to get a successful transplant to work. We definitely practice patient-centered care, but as you can see, on a daily basis, we're talking to so many different transplant team members, and each one of them bring in their different expertise. So we are the transplant pharmacists. We bring in pharmacological expertise, and we'll definitely have surgeons, transplant-specific providers, so cardiologists, nephrologists, etc., social worker, PT, dietitian, our nurses, coordinators, etc. And as a team member, and the measurable impact that I'm talking about here is purely just inpatient pharmacists, but we do bring in measurable impact to our patient care. And just to throw some numbers right here, there's a lot of error and medication risk reduction if you introduce pharmacists into a transplant service. So 61% risk reduction, where there's on average 2 errors per patient that's catched on the time of discharge if you're just talking about medication reconciliation checking. And there's as high as 7% mortality improvement pre versus post incorporation of inpatient clinical pharmacists. And I hate to talk about cost saving, but hospitals love to hear about this. It's actually cost saving if you introduce a transplant pharmacist into the service. Next slide, please. And how do we achieve those measurable impacts? There's actually a lot of patient care activities and responsibilities that we actually do in terms to achieve that goal. So I listed sort of the most important 6 that's on my mind right now, but there's definitely much more to it. So we definitely do attend daily rounds, and that's when a lot of the recommendations taking place. And we do a lot of interventions in terms of pharmacotherapy optimizations. Brittany, if you can click on that once, thank you. And that definitely involves medication management, drug level monitoring, drug-drug interaction identification. Another click, please. Another 2 clicks. Thank you. And transplant evaluation, I won't go through the great details, but there's a lot of things that we actually need to include in our transplant evaluation to make sure the transplant can happen safely. And we also actually take care of the vaccine scheduling at that time point as well. 2 clicks more, please. In terms of transition of care, that's like a huge part of our role, regardless if it's from the patient transferring from the ICU to the floor or from the inpatient side to the outpatient world or between centers. And we do actually do a lot of recommendations. We're checking on appropriate infection prophylaxis in collaboration with our ID fellows. And last but not least, patient and caregiver education is a huge part of our job because the patient transplant medications adherence is a huge part of the post-transplant care. So we do spend a lot of time teaching the patient and also show them the pillbox filling as well. Next slide, please. And this is more for, I guess, pharmacy students if you want to link what we do on a daily basis to what you actually being taught in school. So the key knowledge or the key disease state or drug information that I do find valuable in my day-to-day job definitely include a lot of knowledge in immunology and those high-risk transplant medications, immune suppressions, because they do have very narrow therapeutic windows and a lot of risk for infection, rejection, long-term malignancy. So you do need extra trainings to get comfortable with those. Another click, please. And naturally coming with all of the transplant medications, there's a lot of adverse events or adverse reactions that you see pretty much in all of the transplant patients because of the common immune suppressions they are on. So just to name a couple that you'll probably see throughout the solid organ transplant, regardless which organ you're talking about, like hypertension, diabetes, dyslipidemia, electrolyte disturbance. Another click, please. For me specifically, since I'm in the realm of heart, we do see patients pre and post-transplant. So all the way from advanced heart failure, co-response if they have fatal arrhythmia, ECMO support, et cetera, And last but not least, I personally think your drug information class or literature review class is probably one of the most important skill or class to have. There's very little data still in the solid organ transplant world compared to other fields. So even though there's a rapid growth of what we do, there's also a lot of extrapolating from the general population or from heart as the organ, extrapolating a lot from the kidney literature. Next slide, please. So just to quickly run through a day in my life to put together everything we just talked about. So 7 to 8, we have the selection meeting where I will review or voice any concerns I may have about the patients being evaluated for transplant. We run from 9 to noon. As you can see, this is just a daily theme that you're seeing, like 20 people in the ICU. And then from noon to 12, to noon to 2, I might be helping out with some patient discharges or care coordinations if the patients, for example, is transferring from the ICU to the floor. After that, time for catching up with my residents and students to do topic discussions or just to do some post rounding. And then I have some personal time probably for, can you click on it for a little? Oh, sorry, then backwards. After 3 is essentially time for me to put my other hats on. And we do have after our emergency consults if there's something that's urgent that's going on. So that definitely falls outside of the timeline, but just something that I will be doing on a day-to-day basis. Next slide, please. Yes. And this is, I guess, more geared towards the students, how are transplant pharmacists different from other type of pharmacists? So we do work together as a pharmacy team. Brittany, if you just want to click through the entire animation. Perfect. Thank you. So we work with verifying pharmacists closely to clarify any orders and to handle any home medication or high-risk medications. We work with pharmacy residents, precept them, teach them, and definitely it's a pleasure to have them around. We work very closely with our outpatient pharmacists, and I think April will definitely elaborate more on that after this. And we do work with pharmacy leadership about numerous things, but most importantly, formulary management and high cost medication ordering as well. Next slide, please. And that's, oh yeah, here we go. The day in the life after 3, wearing my other hats. And after hours emergency support, usually someone's rejecting or someone's coding. Next slide, please. So in terms of my other hats, to where I definitely do get very involved in research, a lot of quality and protocol development, and naturally my assistant professor hat for education and teaching, which I enjoy a lot. And to wrap it up, I just sort of want to quickly, I guess, run through how I got into where I am today. So I definitely got my interest in pharmacy during my ABBs. I did a transplant nephrology rotation, which I loved a lot, but I think you will have other type of exposures in your ABBs to solid organ transplant through the rotation listed below. And I did my PGY1 and then PGY2 in solid organ transplant. And I also did a fellowship in advanced heart failure and transplant. And last but not least, I cannot thank the professional society enough for supporting me for who I am, where I am, and especially ACCP Transplant PRN for giving me this opportunity to share my what I do as a transplant pharmacist. That's everything. Sorry, we ran out of time a little bit. There's just too much click in my slides. I do apologize for that.
Thank you, Dr. Wong. All right, we'll save the questions again for the very end, but next we're gonna have Dr. April Pottebaum. Name, just pull up your slides really quick. Okay, can everyone see them? Perfect, okay. All right, take it away.
Yeah, so it looks good. So like they said, my name is April Pottebaum. I currently practice at Nebraska Medicine in Omaha, Nebraska. So the next slide kind of details my training and where I came from. So I'll start there. I actually went to pharmacy school at South Dakota State University, where I had very little exposure to solid organ transplant. So, coming out of pharmacy school, I knew I wanted to do something clinical, but I honestly had no idea what I wanted to do kind of as next steps. So I chose to pursue a residency, and I kind of had a unique opportunity where I was able to commit to a combined PGY1 and PGY2 pharmacotherapy residency that gave me some additional time to really figure out what I wanted to do moving forward. At the end of my PGY1 year, actually, May of that year is when I had my first exposure to solid organ transplant in the kidney transplant population. And I quickly realized that solid organ transplant combined a lot of my areas of interest. So, internal medicine, infectious diseases, immunocompromised patient populations, a lot of those interests areas were kind of aligned here. And so I then went on to really tailor my PGY 2-year to solid organ transplant, although it's not labeled as such. It did function like that. And then really after that, I went straight into the outpatient transplant setting. Admittedly, coming out of residency, I actually didn't know if I wanted to be in the outpatient setting. It was kind of an opportunity to establish the role of a heart transplant pharmacist in a new clinic, expand the role of kidney transplant pharmacist. And so I served at Barnes-Jewish Hospital in that role for several years before I moved closer to family and have been practicing at Nebraska Medicine for the last 1.5 years. And so we'll talk a little bit about kind of day-to-day as an outpatient pharmacist, kind of what we do. So in my current practice, I function in both the kidney transplant clinics are my primary practice area, although I do also practice in the liver transplant side. So a lot of this is kind of going to be a mixture of both, as we do kind of have a lot of the similar kind of setup here. Day-to-day clinical practice involves pre-transplant clinic visit, post-transplant clinic visits, which we'll talk a little bit about on the next slides. We do have a lot of collaborative practice agreements implemented here that allow us to take care of patients kind of independently outside of these clinics. So I'll highlight a few of those and opportunities where pharmacists can really have a big role in optimizing patient care. Respond to a lot of drug information inquiries, both from the patient side of things as well as the provider, nurse coordinators, a lot of questions continually being presented for our patients. And then very involved in some of the other things that were just mentioned in terms of protocol creation, revision, listing meetings, and quality meetings. So to highlight a little bit about, day to day. So on the pre-transplant clinic side of things, that's, for example, a day like today where we have a lot of patients scheduled for their outpatient transplant evaluation. Unlike the heart transplant population, most of the kidney transplant evaluations do occur outpatient. So we do have the opportunity to get to know these people and see them in the outpatient side before their transplant. We start kind of, with an allergy history, medication reconciliation, and really in the pre-transplant side of things, it's getting a good pulse on safety going into a potential transplant. I think one thing with transplant medicine that is, important to note is we think about medication reconciliation, and it is important to know what a patient is on right at this minute, but it's also important to have an understanding of, what the patient's history with various medications has been like. So it's not uncommon that we're seeing somebody who's presenting for another kidney transplant or had a heart transplant and now needs a kidney transplant. Or we see people who have various immunologic conditions. And so in those situations, it's really helpful for us to get an understanding of what immunosuppressive therapies have they been on in the past? How have they tolerated them? Do they have, histories of rejection or infection? And how have these things gone in the past? Similarly, when, we're talking with patients, getting an assessment of their adherence and counseling kind of as needed to facilitate ways to kind of continue to help them improve in that area if it is a concern. We not only talk to the patient or caregivers, but we also get, prescription drug monitoring program data. We get insurance refill queries, those types of things to really help us get a clear picture of somebody's adherence. Do a lot of, also drug interaction identification. So planning for anything that we can in advance, HIV medications, phenytoin, for example, just had a patient on for seizures, and how do we want to manage that at the time of transplant with our anti-rejection medications? And then a lot of, just overarching education at this stage of the game. The nice thing from our side in the kidney transplant population here is, we see people for their initial evaluation, but then also see them on a yearly basis up until the time of transplant. In addition, if there are people who we do have concerns and we really have deemed them not suitable at the present time, primarily due to non-adherence, unfortunately, we do routinely meet with those people every 3-6 months and give an opportunity to kind of demonstrate that they've made growth and help them find ways to be successful before we go into a transplant. On the other side of things, we then have the post-transplant clinic visits where we are also heavily involved. We do meet with people within the first week of discharge, and we assist with pillbox filling. So we have them, bring everything to clinic, and we make sure then with that meeting with the patient that we're able to make sure they have everything they need, clearly understand the information that's been presented to them. As you can imagine, after a transplant, there's a ton of new medication thrown at people at one time, and it's a lot of information to take in those few days in the hospital. And so it's really an opportunity for us to, make sure that they have everything they need and they understand what we're asking of them with the various medications. Certainly help with adherence, evaluation, counseling, any drug interactions that we're kind of dealing with on an ongoing basis, a lot of education. And then really a lot of what we do is optimizing not only the transplant medication, so some things that were just talked about as you think about immunosuppressive therapies and anti-infectives, but also comorbidities. So, from an immunosuppression or an anti-infective perspective, most transplant centers are going to start patients on a general kind of similar regimen. And one of the nice things about a pharmacist is we're able to tailor that for a particular patient kind of based on their concerns and provide some additional insight as to what might be helpful for a particular patient. In terms of, collaborative practice agreements, we actually have a lot here, and it really allows us to optimize the care of patients on an ongoing basis. In the kidney transplant population, we're seeing people in clinic weekly for the first several weeks. So the steroid tapers kind of happen in the clinic visits, but in the liver transplant side of things, we actually manage the steroid taper, call patients as we feel it's appropriate to reduce, and then subsequently discontinue the steroid as part of their immunosuppressive medication regimen. We also have collaborative practice agreements that allow us to optimize dosing of antiviral medications for CMV prophylaxis. Certainly, as patients have fluctuating renal function in the early post-transplant setting, it's important that as that renal function improves, we're increasing the dose of the antiviral medication to make sure patients are adequately protected. And likewise, if we now start to see a decline, that we may back off on that dose from a side effect perspective. Also have a lot of leeway in terms of optimizing PJP prophylaxis, optimizing not only dose, but choosing alternative agents should we need to in those patients. And then managing a lot of other things in terms of stress ulcer prophylaxis, vitamin D levels, electrolytes, things like magnesium is a big one for us, and then blood sugars and hyperlipidemia. So those are all things that we're able to do, as part of the collaborative practice agreement and able to implement outside of clinic visits to really try to optimize care for our patients on an ongoing basis. A lot of these other activities were also mentioned. So in addition to, being in the clinics, answering these questions, calling patients through collaborative practice agreements, there's a lot of time spent educating students and residents, but also healthcare professionals. So certainly that's, in the clinic visits, outside the clinic visits, lecturing at the college, all sorts of things go into that. But, as we talked about the field of transplant, there's always a lot to learn, a lot for all of us. And so it's a great opportunity there. In terms of research, presentations, publications, there's always something to be learning more about. And so really try to take advantage of those things as well, not only for the well-being of my own benefit and my particular patient, but for the field of transplant in general. And I think that's one of my favorite things about transplant medicine is we still have a lot to learn and a lot of things to optimize. And so just fun to see the growth, even in the 10 years that I've been in this field. And then lastly, professional services. So being involved on the institutional level, certainly with committees, both within the transplant department, certainly we are heavily involved in terms of listing meetings, quality improvement projects, those sorts of things, but also, just the ambulatory care side of things for me, optimizing how we do documentation and kind of looking at our metrics and kind of what we do on a daily basis, and then certainly also professional organizations. So high level overview, but on the outpatient side, certainly a lot of opportunities for patient interaction and ways to optimize care there too.
Thank you, Dr. Padabam. Okay. Next up, we're going to have Dr. Abby Leno. Let me just go ahead and share slides as well.
Better. Okay. Are you having any breaks?
The slides come up. I kind of took a slightly different path with my slides, and I'm going to go more through my career journey just because research can kind of vary and there's lots of different ways how you can get into research and lots of different types of research. And so since most of you are students, you may not be super familiar about what is the best pathway to get into research, and really what even is research and what kind of research is available to be done. So we'll talk about that today. So next slide for us. All right, so this is my path, and it was longer than many people's, shorter than some people's, and there's really no one size fits all way to get here. And if you talk to somebody else, they may have an entirely different opinion than me as you move forward. So I really encourage you to keep attending things like this, talk to people, and figure out what's going to work best for you and what your career goals are. But I'll certainly share my thoughts as we kind of move through this journey today. And so my journey started with clinical training. My PharmD was at the University of Michigan. And kind of my first big turning point, to use my path analogy, was as I was beginning to wrap up the PharmD and where am I going to go next, right? I'm sure most of you PharmD students are aware that the PharmD really is only the beginning, right? There's so much more to learn once you finish your PharmD, particularly if you want to go into something like clinical practice and be a transplant specialist or go into research. You likely, probably in this day and age, are 100% likely to have to do additional training. So what does that look like? And so I was meeting with a bunch of people trying to decide, all right, do I have another slide? I can't remember if I deleted this or not. Could you go advance us one slide? No, okay. Well, so is it a PGY1? Do I continue my clinical training, right? Like I had decided I wanted to be a pharmacist because I wanted to take care of patients. I wanted to make a difference in how we manage their medications. So do I keep learning that? Do I do a residency? Do I do a fellowship? And if I'm going to do a fellowship, do I do an industry fellowship and do more industry focused research? Or do I do an academic fellowship? Where you go work with a professor and help them manage their research? Or do I do something combined, like UNC has a bunch of combined programs where you do academic for the first year and then you go into industry? And for me, I knew that I wanted to understand more of the clinical, that if I wanted to make the difference that I had in my mind on patient care, I needed to know more about patient care. So I did a PGY1. And then a PGY2. And so now we can go to the next slide. The big question, though, to help you make these decisions at these turning points is what type of research do you want to do? And the two big things that kind of dictate what type of research you're able to do are the time to do it and the money to do it. Research doesn't just happen. You have to put in the effort to make it happen. And you oftentimes need money, particularly if you want to do more interventional prospective type work. It likely is going to take money, and at very least money to buy your time out of clinical work. And then supporting all of that is additional training, getting experience with research, and mentorship and collaborations are sometimes an option if you're not able to get some more of that formal training or experience. All right, next slide. So there's lots of different types of research. So there's the benchtop, the basic science, where you think about test tubes and potentially animal studies, although we're moving away from animal studies. With the NIH reducing the amount of funding they're going to provide for that realm. And it really provides us the biological understanding, maybe a new target for drugs, what molecular structure is going to fit that target, that sort of thing. So if you don't do additional training like a PhD or something, it's probably unlikely you're going to be leading basic science research with a PharmD alone, but there are people who do it. Then there's more translational research, which is kind of where I fit in my current realm, and that's where you're doing things like, all right, maybe somebody's discovered this new biomarker and you're contributing to understanding how that biomarker might fit in patient care. And then there's clinical research where you're doing, the randomized controlled trials to test out that biomarker or that drug. And then there's population-based research, which is understanding how do we put this into best practice, maybe implementation science. We have all of this great knowledge, and then most of it doesn't ever make it into practice. How do you take that great science and move it into practice? That would be considered something along the population level. So there's lots of different stops in this research journey that you could choose to take. So in residency, this was one of the places where you might get exposure to research training. And something to think about if you want to do research as part of your career and you're going to do a residency. The primary focus is on developing as a clinical pharmacist, and that's where most of that time piece comes in. And you're likely not going to have a lot of money for a project and not a lot of time. And so residency projects, they're not called research projects, they're called residency projects, and not all projects are created equal. Not all would probably even be considered research, and they're likely to be small and retrospective. And so I'll tell you on the next slide what I did in my PGY1 project to give you an idea. And so this was kind of more along the lines of a drug use evaluation. So they had changed their policy for a drug called dexmedetomidine, which was newer at the time and was very expensive. And so in the year before I got there, they had said, we're going to let you use it when previously it was restricted on formulary and they were not allowed to use it in the OR for cardiac surgery patients. But there was increasing data in adult patients that, this reduces opioids, gets you off the vent faster, reduces your ICU length of stay. And so we'll maybe let you use it. So my goal was to look at the data and say, well, do those things actually happen in pediatrics? So this is kind of a pre and post design, all retrospective. So there's going to be limitations with sample size. And so you can see I only had 30 patients because we look at the 30 who were done in the year after the change and 30 people who matched them in the year prior to the change. And we saw less fentanyl exposure, but that did not correlate to a reduction in the mechanical ventilation. So while less opioids is good, it didn't have an impact on bigger factors. And so on the next slide, a similar project was what I did in PGY2. So I decided to do a PGY2 in solid organ transplant kind of at the last minute. So I actually was interviewing for pediatric residencies for PGY2, did my transplant rotation in like February or March while I was interviewing. I was like, oh, crud, I like transplant. I want to be a transplant pharmacist. So I actually withdrew from the match and scrambled into transplant. So it's okay to do scary things sometimes, and things can still work out okay. So always follow your passion. I feel like can be life lesson number one from my talk is scary things can sometimes turn out okay. So luckily, I was able to scramble into a position at The Ohio State University, and my project was looking at infectious outcomes when we use plasmapheresis and a really strong drug called antithymocyte globulin that depletes all of the patient's T cells for mixed rejection, compared to people who just get the ATG. So the plasmapheresis removes all of the existing antibodies from the blood. So the hypothesis was people who got both would be at higher risk for infection, and we saw that. So if you got both, you almost 40% of patients had an infection in the 30 days after treatment, compared to only 10% if they just got the ATG alone, which makes sense because antibodies have a half-life of about 30 days. And so if you remove them, it takes about 30 days for those antibodies to come back. All right, next slide. At Ohio State, we had a statistician who was able to do more complicated statistics for us. And what we ended up finding is that when you control for all of the potential confounding factors, there really was no difference. So even though our initial simple statistics look good, when you start to get a little bit more complex, there was no difference. And so next slide, all of that really fast review of my two residency projects are There are often limitations to residency projects. They have really low publication rates. The small sample sizes are probably going to make it harder to find significant results because they're often retrospective. There's confounding factors that will limit the usability of your results. But you can learn a lot about research during your residency. And so if research is something that's important to you, think about how you can evaluate those programs from that perspective as you're going to different residencies. Do they actually consider their projects to be research projects versus just a drug use evaluation? How much do they teach you about statistics and how to do high quality research? Or do they just give you a statistician and you're not going to get to understand any of the reason why they made those decisions? So those are all some things to keep in mind. And again, it's okay to pivot, right? You can be that person that scrambles and head in the direction that you really want to go. All right, next slide here. So after residency, I was really lucky. My residency program director introduced me to the fellowship program director at the University of Cincinnati. And since I knew I wanted to do research from the very beginning, fellowship seemed like the next reasonable step. I had just done 2 years of residency. I wasn't ready to totally give up on the clinical practice that I had just finally felt comfortable doing. And so I did a fellowship. And so this really gave me the opportunity to do the type of research that requires the time and the money. I didn't have to get the money, but it was needed to be there to happen. So this was more like the randomized controlled trials where you were comparing 2 different drugs and things like that. I got a master's at the same time to give me that knowledge and that formalized training in statistics and grant writing and all that sort of stuff. All right, next slide. After I finished fellowship, I took a clinical job, and clinical jobs are busy, busy, busy. You just heard 2 speakers tell you all the things that they do in a day. And I imagine they both try really hard to do research, but research often, if that's a passion of yours, gets pushed to your personal hours just because there's so many other things that the teams rely on us for. And so for me, I knew that that really wasn't what I wanted to do. And while I learned a lot during this first job and continued to reinforce what things we really should be studying with research, I wasn't going to be able to do it in that job. And so I woke up one day and I was like, I am not happy in what I am doing. And so how can I get to do research 100% of the time fastest? And so that's when I went back to get my PhD. And so I got to do a randomized controlled trial that was my own idea, that I was provided with time and money to do it. And I learned a ton through this experience. And so now that I have my PhD, and I think in today's funding world, if you really want to be able to fund yourself and do randomized controlled trials, interventional trials, translational research, anything really other than retrospective chart reviews, you're going to need to get formalized training. My opinion is that you probably need more than a fellowship, although there are probably people who will debate me on that. And so I'm really, really happy with my decision to go back and get my PhD. And so here I am now in my first research position at Cincinnati Children's, where I get to spend, yes, you can go to the next slide. And I'm a lot of focus on grant writing. So at some point, when you get far enough into a full-time research career, you get to do less of the fun stuff like talking to patients and enrolling them and following them, and you have to hire people to do that for you so you can continue to write the grants to get the money. And so if you want to lead studies at some point, all you get to do is grant write, which luckily for me, I love, but that's just something to think about as you're heading down this path. You get to see all the really cool results, but sometimes you do feel a little removed from the patients because you're not the one who's there at the bedside or in the clinic with them anymore. And so I think it's done. I want to make sure I give our last speaker enough time. So thank you, everybody.
Thank you, Dr. Luna. Okay, so our last speaker is going to be Dr. Jen Gray. Let me go ahead and share the slides. See, 1 second.
All right. Thank you, everybody. I will talk fast so we have time for questions. And then certainly if there's any questions offline, you can get my info and kind of let me know what questions are on your mind. But I'm Jennifer Gray, and thank you to you all to have me here. And today I'll talk about the industry viewpoint, which I will kind of shorten down because you heard the last three speakers give their path and how they got to where they are. I have a really similar, if you can go to the next slide, Brittany, please. I have a really similar pathway as well. And then just recently, well, not even recently now, about 6 years ago, took the jump to industry. But I also was in pharmacy school at the University of Pittsburgh and really thought I got the short straw, got a transplant rotation, was very nervous about it and was there for a day. And found out very quickly that this is what I wanted to do for the entirety of my career. So I really kind of pivoted from there in pharmacy school and knew I wanted to do a residency, but sort of changed my sights to an all solid organ transplant vision. And so I did my PGY1 at Vanderbilt, and that year we set up a PGY2. So I was able to stay on as their first resident and helped kind of set up that residency, which back then there weren't that many, and now there are a lot. So I've seen a lot of change within the solid organ transplant world, which has been a really neat experience. And from there, I then stayed on at Vanderbilt, luckily was offered a job and stayed there for the next 12 years, was mostly lung transplant, did some heart transplant as well. And then my last few years there became the residency director. So I really always had this interest in kind of both sides, the really clinical side, but also managing people and kind of understanding what other parts of the practice look like. And so I won't go through kind of my day-to-day, but everything that the ladies before me just talked about, that's exactly what I was doing as well. And if you go to the next slide, Brittany, please. Same as you've heard, it was rounds. And I was also inpatient and outpatient. So I was expected to be trying to round in ICU, round and step down, and then also get to clinic on time, which you might imagine that's impossible. And so there was really just a lot of kind of scheduling issues, concerns, coverage. We were doing weekends, but then getting a comp day. But transplant is really hard to have a comp day. It's hard to be off whenever you have a clinic scheduled. And so I had just gotten to the point where 12 years in, I thought, man, I probably should be looking for my next steps here. And lo and behold, a recruiter called sort of very shortly after I started having those feelings. So next slide. I went to CareDx. And so I got that call from a recruiter, did the interview process knowing that I had no industry experience, but then was able to make the leap. I have here what our kind of two main products are, because CareDx is probably quite different than what you would picture typical industry. So we don't have any drug. This isn't big pharma. This is a diagnostics company that's using cell-free DNA to look at graft injury. And then for the heart side, we also have a gene expression profiling molecular biomarker. And so I took the leap into the CareDx field, really being very kind of generalized. Brittany, if you go to the next one. I came in as a medical science liaison. And so I just had like a really quick snapshot of what each of my roles have sort of looked like and what the day-to-day is. Most of you, if you would go into the industry side, would come in as a medical science liaison, unless you have sort of a different path and decide to switch to something like marketing or even sales. We have a lot of MSLs that then went on to work for the sales team. But I came in as an MSL, so I really was serving as kind of the medical and scientific expert within the company. We would do a lot of public speaking, a lot of talks to transplant centers all around our technology, how it can be beneficial in that practice. And then really trying to put together publications, trying to get research started. So kind of a little bit different than what Abby does is actually conducts the research. We were trying to get ideas for research and kind of push it forward from an industry sponsored standpoint. From there, I got promoted to senior MSL, and that really kind of expanded my MSL responsibilities. It expanded the territory that I was following and sort of responsible for. At this point, then you get to sort of organize conference symposia. So the big symposia that you all see at these medical conferences and kind of ISHLT, ATC, we get to be part of that as kind of in that role. From there, then I went on to become the regional director. And so my area was heart and lung transplant for the entire East Coast. And so from there, you really now have a team of people that are reporting up to me. And I was onboarding the new hires. We do all the training for the company so we can fly out to the home office in San Francisco and do that training to anybody who's newly joined. So the sales team, the marketing team, kind of a really big collaborative work. And it is still multidisciplinary, not the same as we did in rounds, but we do work with a bunch of different divisions within the company to really kind of get our work done and completed. And so from here now, I've been lucky enough to become the national director for lung transplant specifically. So we have really shown the value of being able to be organ specific, much like we were when we were in our clinical practice. And now I have a team of MSLs that are functioning all only in the lung transplant space. There's 3 of them. So it's a lot of travel. There's 3 of them covering the entire country, Canada, Mexico, the rest of the world. So it's really busy work, but it's busy as far as trying to keep up with the schedule, but it's really been great to focus in on lung transplant, get publications together, do research conducted all within that lung transplant space. And then you see here, I've been able to expand my learning beyond my clinical, pharmacy background, and got some into helping with marketing and sales and just general business knowledge. The corporate world is not for everybody. Certainly it's quite interesting out there. And so kind of learning the ways of corporate and business and things like that have also been part of what I've done over the last 6 years. And it is not the dark side. When I was in school, it was very much targeted as do not go to the dark side. And I assure you that it is not that. And so I'll just give quick, I know we have 5 minutes left for questions. I just wanted to say quickly, because there are a lot of really good pros and cons. And if you all are out there thinking, well, I want to do industry at some point, but I want to do some clinical practice, I think that's really smart. I was in clinical practice for much longer than the majority of sort of the industry MSLs or others that come over. But there are things to think about, and there's definitely downsides to it. You've just gone to pharmacy school for a very long time. And then as the others alluded to, you have to do then clinical training after that. In most cases, so you spend a lot of time in school. And now one of the things is that I don't have direct patient care. I still am getting to talk about drugs. I still get to talk about patients, but I don't get to speak to them. I don't get to directly impact their care day to day at the bedside as I was for the, decade plus before joining. But I will say the good things here is that I'm meeting with leaders in the field from all around the world. We get to know now lung transplant specialists from, everywhere, all around the US and the world, and not just the center that I was practicing at before. I do get to travel a lot. It's usually a benefit. Today, right now, I'm sitting in an airport talking to you all. And so if it gets loud, you'll know why. So I have travel as kind of a pro and con, because as you know, living out of an airport is not fun. Delays, kind of everything that's happening in the world at this point. Sometimes travel is a con, but I get to have a flexible schedule. We get to work from home. We're not doing weekends. And you heard the first speaker talk about that kind of late night. There's someone crashing and burning. That was my life for, 14 years. But the one nice thing now is that is not technically the case anymore. But I do miss that multidisciplinary team. I miss the patients, and I miss kind of being in the hospital and really seeing those patients who can do well. So again, something to think about. There's pros and cons of everything, but with the last little bit that we have, happy to take questions from all the speakers. Can hopefully have a couple questions for them.
Thank you, Dr. Gray. Thank you, everyone. It's been a great session with 4 amazing speakers. I know we're limited on time, so sorry about that. But I'm going to pass it on first to Stephanie to see if there are any questions that were directly messaged to her, and then we'll see how many we could get through in this limited time.
Yeah, I'll echo what Brittany said. I thought this was fantastic. I loved hearing about each and every one of you's day to day as a transplant pharmacist and all of the different hats you all wear specifically within each individual realm. So I thought that was amazing. I didn't get any questions specifically messaged to me, but since we are limited on time, I think I'll just ask one, and any speaker can feel free to chime in. This isn't directed to any one of you, but Brittany and I thought this was a good question specifically for students and residents on the call. So what is the single most valuable piece of advice that you would give to them, especially for, students who are about to, maybe go through the matching process and all those types of things. So kind of what is the most important piece or valuable piece of advice that you see every day that you would give to these students and residents?
All right, well, I'll go fast. Why it looks like others might be coming off mute. I would say, I loved transplant from the very get-go, and I knew that I wasn't going to leave the clinical practice unless I was able to still practice in that area that I loved, is specifically lung transplant. I think somebody else alluded to this too, that you know what you like when you're there. It kind of hits you, and you can't get rid of that idea of like, this is the subspecialty that I love. And I always sort of had a vision of having a specific lung transplant team at this company. And through hard work and kind of dedication, we now have that. So I would just say, whatever your subspecialty is that you find that you like, just really stick to it, and you can really make it even more than what you might think, and even more than the opportunities that we all had given to us, you can kind of create your own as well. So find what you like, stick with it. It'll do you well.
Yeah, to follow up on that, honestly, I think some of us had a more direct career path and others not so direct. And I think one of the biggest things I've learned along the way is just to remain open to the opportunities that are available to you. As I was finishing up residency, I honestly didn't think an outpatient setting was exactly where I would end up. I, took the job and was like, oh, I was hoping to get back inpatient within a couple of years, but it seemed like a good opportunity at the time. And had I not, kind of followed that intuition and just given it a chance, I never would have identified that, like, this is where I want to be. And so along with that, just remain open to the opportunities in front of you, and excited to learn and grow because, all of us, I think, look back and it was all worth it, even if it wasn't exactly how we thought it was going to go at the time.
I guess I'll go. I'd say be persistent. So if you find your passion, even though it sucks being a resident, I never want to look back again to those years. Just kidding. I love what I've learned, but push through the training if you have passion, push through with that project, even though it involves like late night data collection, or it sucks to have 40 comments on one page for your paper. Push everything through and you will be very proud of where you are and how far you've go through.
And just because I can't be the only one not to speak, I think I kind of told you my big takeaway, right? Like, do what is going to make you happy and make you fulfilled, even if it's scary, even if it's going to take you longer. Your career is long, right? I was just in your seat like yesterday. And now I'm like the senior person who has done a PhD in residencies and fellowships and like has a real job. And it was just yesterday, and I still have 30 years left to go in my career, right? So your career is long. You have the time. Don't let anybody convince you otherwise. I know there's lots of family commitments and financial things to consider, and not everyone has the opportunity to just like continue to train forever like I did. But if you want to, and that's where you want to end up, don't be afraid to make that decision. You have a lot of time in your career.
Those were all great responses. Thanks so much for sharing those. We did actually have one question come in, so we'll answer this really quick. Are there ways to become a transplant pharmacist without doing a PGY2, or are there more programs besides what are listed on the ASHP website? I see that the website has only around 30 sites listed that offer a PGY2 in transplant. So essentially, are there other avenues to become a transplant pharmacist without doing an ASHP PGY2?
Getting really lucky. Because most jobs are going to want you to have had transplant experience to be a specialist. Doing the pharmacotherapies, like we had a couple of people who talked about that. But again, there's not a whole lot of those. I don't feel like people go unmatched. Maybe somebody who's younger than me can talk more about what the match situation has been lately, but I feel like there's usually positions, in the scramble opportunities. So I wouldn't let the number of positions of residency persuade you from at least, trying.
Yeah, the only thing I've seen, is that sometimes, and again, this is coming from somebody who really didn't know what I wanted to do until a little bit later, but sometimes people will do like a cardiology residency, and during the cardiology residency, they'll realize they have an interest, particularly interest in transplant, right? So there are, for example, cardiology residents that are hired for heart, lung transplant positions, those types of things. Have also seen, people interested in infectious diseases subsequently end up kind of working as lung transplant pharmacists because their kind of area of interest has kind of tailored to that. So I think most people are going to have a second year residency. But I think the exact nature or label of that sometimes over time can grow and can be molded if you subsequently find out that there's a strong, niche interest in transplant within that kind of field.
I would agree. Thank you so much for sharing those responses. And I don't see any more questions. I know we're a little bit over time, so I thank you all so much for staying on the call a few extra minutes. And again, thank you so much to all of our speakers for taking the times out of their busy days, as they all echoed they have busy days. So we really appreciate this, and we will wrap up for the day. Thank you so much and have a good rest of your afternoon.
Bye, everyone. Thank you.